Amazing. So welcome once again to our 6th annual Sickle Cell Disease Summit. I think I don't need to introduce myself. I've met many of you in the last session. For those of you that don't know me, Dr. Dana Powell. And I hope so far you guys have enjoyed the afternoon sessions, because I definitely have. There's been great discussion, excellent questions, and I think this room is all fired up and ready for this. We're going to have some flash presentations here. We're pleased to bring everyone back together in this space to hear from our presenters and have their research highlighted, their initiatives related to sickle cell disease. I'm pleased to be moderating the research abstract oral presentation sessions. Of course, reminding you of the housekeeping rules, just making sure our phones are muted, washrooms, are located to the right side of the hall, Wi-Fi access on the screen, and of course, after each session, please complete the surveys. All right, so during this session, it's a little bit different. You see lots of lovely faces up here. We will hear a series of 5 oral presentations highlighting research and initiatives, as I've mentioned, from each of their institutions. Following each presentation, we will open the floor for questions, okay? So hold your question, and then after each presenter is gone, we will run the mic around and give you an opportunity to ask our presenters about their research initiatives. So first up, I'd like to introduce to you our first presenter, Ms. Beatrice Floris. Hopefully I've said your name correctly. She'll be presenting her abstract entitled, "Is the Edmonton Symptom Assessment Scale an effective symptom assessment tool in adult patients with sickle cell disease in a comprehensive hemoglobinopathy clinic?" Please join me in welcoming Ms. Beatrice Floris.
Hi, good afternoon, everyone. So my name is Beatrice Floris, and I recently graduated from a Master in Translational Health Science from the University of Windsor. And I'm here to present our initial findings on the use of the Edmonton Symptom Assessment Scale, or ESAS, for symptom reporting in patients with sickle cell disease. So before I begin, I have nothing to disclose. So patients living with sickle cell disease experience complex and fluctuating symptoms. So how can a standardized symptom assessment tool really capture their experience? So the ESAS is a patient-reported outcome that assesses 9 common symptoms, including pain, nausea, and depression, and it assesses them on a scale from 0, no symptoms, to 10, worst possible. The ESAS has been validated in oncology care, where it has been shown to consistently improve patient care. And it has been shown to be feasible in sickle cell disease care. However, patient perspective remain underexplored. So our objective was to explore patients' perspective on the feasibility and efficacy of the ESAS in capturing relevant symptoms during routine care. So this study is being conducted at 2 adult comprehensive hemoglobinopathy clinics in Ontario. So one is Windsor Regional Hospital, and the other one is Hamilton Health Sciences. This study is being conducted in 2 phases. So after completing the ESAS, patients are given an experience survey with Likert scale and open-ended question to assess their initial experience. Patients are then invited to complete a semi-structured discussion to explore more in depth about their experiences. So what we want to ultimately understand is whether it is practical to include into care and whether it captures relevant symptoms. So far, we only had 16 patients from Windsor Regional Hospital. Most of these patients were aged between 26 and 40 years old, and we had an even number of males and females. So the graph shows on the bottom the number of patients, and then on the Likert scale whether they strongly disagree to strongly agree with the statement. So all patients were able to complete the ESAS without assistance. 94% found it easy to understand, and 81% were willing to complete it again. And patients also found that it did capture relevant symptoms experienced. Beyond the ease of use, 68% of patients found that their care was more personalized. However, there were patients who disagreed with the statements. Also, 62% of patients found that it helped them better understand their health. Overall, from this survey, we observed that the ESAS was easily understandable and can be put into practice. However, there can be made adaptation for sickle cell disease. So far we conducted 3 interviews, and so we found some common themes. So the ESAS was easy and to understand and a good starting point for patients to discuss their symptoms with the provider. However, it did not capture relevant symptoms. For example, they're missing like jaundice, edema, and changes in fatigue. Patients also found that the symptoms needed more context. A number from 0 to 10 was not enough to understand, to make the provider understand. For example, pain can be very complex. It can be ongoing and chronic, or it can be the acute pain of a sickle cell crisis. So from these preliminary findings, we found that the ESAS can be adapted to sickle cell disease and to better capture the symptoms. So what do we go from here? So preliminary findings suggest that the ESAS has a strong foundation. However, it does need to be adapted to better capture symptoms and the complexity of these experiences. So there is an opportunity to build on what already works. Recruitment for this study is still ongoing, and it is important that patients remain a part of this process. Because we are using these tools to understand their health, it is important that the voices should help shape it. Yeah. Thank you, everyone, for listening.
Perfect. Thank you very much. That was very much on time. Excellent. Are there any questions? Any questions before we move on? Nope. I guess that was super crystal clear. Thank you very much.
Thank you.
We're going to keep it moving now. And in the essence of time, I'm going to introduce you to our next presenter, Miss Valerie Jansen, who will be presenting her abstract entitled Improving Equity in Pediatric Sickle Cell Disease Emergency Care. Please join me, everyone, in welcoming Miss Valerie Jansen.
Okay, hi everyone. I'm Valerie Jansen. I'm the clinical leader for the Pediatric Emergency Department at McMaster Children's Hospital and Hamilton Health Sciences. I have no disclosures. The information that I'm presenting is part of a quality improvement initiative, so not formal research, but still very data-driven decisions. So this quality improvement initiative started when we got some patient experience feedback. And so this is one of my favorite places to start for QI is the voice of the patient. We had a teenager that came in Vaso-Occlusive crisis with severe pain, and unfortunately had a history of difficult IV access. So required multiple IV attempts, which obviously is not very fun. And it also delayed the pain medication administration. So those things combined obviously contributed to a poor overall experience. I don't think anybody loves coming to the emergency department, but this is not the type of experience we want for our patients. And this was also in the context of ongoing work at McMaster Children's Hospital to update our IV escalation protocols, emphasize vein-sparing principles, so saving veins from unnecessary pokes if we can, and the implementation of difficult IV access scoring, which uses skin tone and vein visibility as variables to predict when someone's going to be difficult access. It's also in the context of advocating for vein visualization technology, so equipment that we can use to help with IV access. So we kind of noted that we've got 2 main problems. Number 1, we're not meeting our target time to pain control based on the Ontario Health Sickle Cell Disease Quality Standards. And we knew that we didn't meet it for this patient here, but we also did a chart analysis to look and see how have we been performing over the last little while. And when we look at patients that required IV-dependent care, we were not only not meeting target, but it was about 12.5% of patients that did meet target. We also did a data collection on IV access attempt and first attempt success rates in patients with all skin tones, and we noted that our IV success rates actually decreased as you get into the darker skin tones. So bringing us to kind of our analysis of that is that, we have other methods of administering pain medications, but we're still really dependent on IV analgesia for care. And then we also noticed that there's that disparity in IV success rates, and how can we improve that, possibly with vein visualization. And vein sparing principles are especially important in kids, but even more so in patients with sickle cell disease, so that we don't need to progress to more invasive lines or have IV access be a barrier to care and pain medication administration. So the goals were that we wanted to meet the time to analgesia based on the Ontario Health Standards. We wanted to improve our first attempt success rates in patients with dark skin tones to get to that of patients with light skin tones. And we wanted to educate staff while we were educating about our new protocols to include, trauma-informed care, the importance of, language, and then the acute and chronic complications of sickle cell disease. So our improvements were kind of multi-pronged. So the first was to implement a multimodal pain analgesia pathway that did not require an IV. So we administer as soon as possible after presenting to the emergency department 4 medications: intranasal fentanyl, oral morphine, oral acetaminophen, and oral ibuprofen. And that allows us to get the pain under control. If they do then require IV, we have more time to prepare the patient, put on numbing cream, do the things that can actually improve the overall experience of IV insertion. The next was to implement near-infrared vein visualization technology. So that's that second photo you can see there. This helps us see patients' veins and helps us then improve the success rates of IV insertion. And then we had the education pathway that went along with all of these things. So educating on our new protocols in addition to the other topics I already mentioned. So the results were pretty positive. So of all the patients that we audited after the implementation of this standard protocol, we used the new order set in 81% of eligible patients. There was a couple patients that did not meet criteria because of their age, but when we looked at the patients who received the oral and intranasal pathway, we were able to bring that average time to pain control to 30 minutes from triage. So actually meeting the target, which was super important. And then looking at kind of our IV success rates after implementing vein visualization technology, we were actually able to achieve an 18.6% increase in first attempt IV success rates with the use of a near-infrared light. And so overall, it improved the patient experience and family experience. So we had a patient come in shortly after that. It was a toddler who was in severe pain, inconsolable crying. Our physician used the new pain management protocol. And shortly after administering, was able to settle, and the mom was very pleased with it and asked if we could continue to use this pain management again in the future. So next steps for us are to continue to gather the lived experience of our patients. It's where we started our work, it's where we want to finish our work and continue to improve. We want to get our compliance for that order set use to 100% so that we're using it on all patients. We want to expand the use of vein visualization technology, so we've been able to see that it is helpful in improving success rates in patients that we maybe have a hard time seeing their veins. And then we've recommended that we utilize a similar order set in other emergency departments across Hamilton Health Sciences as well, so that they can replicate the same work in adults. And then the last thing is just to find a sustainable way to track, data and outcomes. And then after hearing a lot of other experiences today, it would be really great to loop back with that patient who provided that initial feedback to us to let them know these are all of the improvements that we've been working on based on their feedback. Thank you.
Thank you very much, Ms. Jansen. Any questions from our audience? If not, okay, yes, we have quite a lot of questions. Okay, 1, 2, 3, we have enough time for all 3, and I can save my third.
Thank you. My name is Riyad Elbart. I'm a thalassemia patient, and last year I was hospitalized in February, March pneumonia, and a lot of things went wrong. So I needed to be admitted in the hospital. And part of the protocol is to do blood work every day. And when I was in emergency, I had an IV in my hand, and they were able to draw the blood from my hand. But when I was put on the ward, they're like, no, we have to poke you. And I'm like, you're not going to do that. So, but anyhow, I got into an agreement with the supervising physician that you can draw blood once a day. If you miss a blood test, you're going to wait till tomorrow. And I was very firm about that, and being the stubborn person I am, so they agreed. My question is, what can we do to change these blanket protocols, blanket treatments for everybody when you have somebody who is chronically transfused or who has a chronic illness and really depends on their veins for the treatment that they receive for the rest of their lives? I mean, yeah, we do the visual assisting devices to get the vein, but that's not the problem. Is to actually save the veins, because you might not even have the veins, or if you have one or two good veins, you really want those to last you as long as possible. Anybody actually could answer that what can we do to get the hospitals to kind of take into consideration those situations?
Yeah, so I think there's a few things. First is that, we are able to blood sample off of IVs. I think it's very dependent on institutional policies, whether they allow that. We're very good about doing it in pediatrics because, of course, kids don't like to be poked, but no surprise that adults don't like to be poked either. I don't think there's anybody that enjoys it. But I also think that's where some of the vein visualization technology can come in, so that we're not utilizing those same veins over and over, contributing to that scarring and then limiting the options that we do have. Because I think it's easy enough to, see the one that you always go for, that always works, but, that only works for so long. So I think it's partly on the hospital policy side to look at how they can, implement those vein-sparing principles in adults and in peds. And then it's probably also like a patient advocacy thing as well to, communicate that that's not going to work for you and your care plan.
Yeah. Thank you very much for your presentation. I was really interested in the oral intranasal pathways that you mentioned. That is phenomenal. And I was just wondering, is this going to be a standard practice for our other major hospitals that get patients with sickle cell that walk in and they're not struggling to delay the meds because they can't find the vein finder or they can't find the patient's veins? Thank you.
Yeah, and that would be the hope. And so, we've demonstrated that we've been able to meet those target times in pediatrics, and we're going to recommend, obviously, that they expand that protocol to adults. But the intranasal fentanyl is really nice because you don't need IV access. It starts working in about 5 minutes, and then with that other combination of medications that we're giving, as it's peaked and it's starting to wear off, the other medications are kicking in. So it's not that kind of roller coaster. You're actually kind of layering so that you get that adequate pain control. Whether or not that becomes standard everywhere, obviously I can't speak to that because I only really have control within my own institution, but I do think that, we've proven that having care that is not IV dependent can be really beneficial, even just for the experience of having an IV inserted when you're not already in severe pain. I think that's super important. So yeah, hopefully we can share this work a little bit more, and maybe we'll get there someday. I would love that because I think it's really improved our patient experience. So I would love for it to improve in other areas too.
We have one question over here from our other presenters, from Karen and go ahead. Yeah, it's both of you.
You kind of had to let me ask a question, right? Thank you.
It's cutting into your time, by the way, Sandra.
Oh, man.
I'm kidding.
Thank you very much. I love the innovative, always searching for new ways to improve the way care is delivered. I'm excited about the adult extension potential. I just wanted to ask how widespread this laser, not laser, you used another word that is
Near
escaping
infrared,
me,
yeah,
my
I know,
friend.
sorry.
That's what I meant. And
Yeah.
how extensively that's used, and is there a cost or time element that would be a reason it's not used more widely? Just wondering about barriers.
Yeah, so in terms of barriers, to be perfectly transparent, I had to advocate for a really long time to get that technology, and it's because when they have assessed it previously, they assessed it in adults and light skin tones, and they said it doesn't improve our success rates at all. And so that's actually what drove the data collection and me doing all of my own data to support the ask, because it's been, I think, prematurely dismissed, especially when it's potentially helpful technology for people with dark skin tones. So I don't think it's as widely used right now. I also had a hard time finding data that was not biased and not kind of produced by the companies that create the devices, which was another kind of motivator for me to do our own non-biased data collection. But I do think that technology has come a long way, and anybody who looked at it 10 years ago maybe would say it didn't work, but I think it's gotten a lot better, and it's worth looking at again. So again, we've recommended that we start in peds and use it on all patients with dark skin tones, but I actually have recommended next that they expand that to adults, and so slowly we'll be able to hopefully expand that use and prove that it's helpful.
Awesome. Thank you, Ms. Valerie Jansen, for your research. We'll move on to our next oral presentation. Our next presenters are Tanya, Louca, and Amanda Schwartzman, who will be presenting their work entitled Evidence to Practice Sickle Cell Disease Vaso-Occlusive Pain Episode Emergency Department Toolkit. Please join me in welcoming Tanya, Louca, and Amanda Schwartzman to the stage.
Good afternoon, everyone. Thank you so much for having us here. We're very pleased to be at the SCAGO Summit this year to share the work from Evidence to Practice Ontario, focusing on the Vaso-Occlusive Pain Episode Emergency Department Toolkit. Please feel free to scan the QR code for access to the toolkit itself, and we'll share this again a little bit later. We have no disclosures at this time, so let's go ahead and get started. My name is Amanda Schwartzman. I'm presenting today with Tanya, Louca, and today we're going to give a very brief overview of the toolkit, how it supports implementation of the Ontario Health Quality Standards, and what organizations can take away to support change in emergency department care. So what is Evidence to Practice, or E2P? E2P was designed to help clinicians access best practice supports, reduce the efforts required to apply those practices, and to ultimately improve the experience of care for patients, caregivers, and providers. At its core, this is really a translation problem. We have the evidence, we have the Ontario Health Quality Standards, which really describe what high quality care should look like, but if that evidence doesn't show up in the workflow, inside the hospital information system, and at the moment that clinical decisions are being made, then it does not reliably change patient care. At its core, this is what E2P is about, is closing that gap. So let's talk about the quality standards. Apologies. So this is what we refer to in the toolkit as the E2P intervention bundle. These three categories of the bundle were designed to collectively address known gaps or barriers to timely pain management in the patient care journey from the moment that a patient enters the ED. This is not just a digital build, this is a people, process, and digital workflow change. The order set helps to embed the quality standards directly into clinical workflows. The standard operating procedure helps clarify how teams identify patients early and communicate quickly within their team. And education is essential so that teams are equipped to provide care in a culturally competent, anti-racist, and anti-oppressive way. Additional change ideas do, of course, vary at the local level, and they were largely dependent on the maturity of an organization's health information system. Some examples included adding sickle cell disease pain as a kiosk patient check-in item, physician or NP notification through team chats, and adding the order sets to ED quick lists for improved visibility. So let's take a look at the toolkit itself. The toolkit is designed to bring all of these pieces together so that organizations do not have to start from scratch. One of the strongest lessons learned is that success comes from implementing the key activities collectively and not in isolation. So for example, a site made updates only to their order set, but they didn't introduce a standard operating procedure or policy guiding teams on how to apply the pathway, and the organization ultimately did not see more timely access to pain management or see improvements in their order set utilization. With that framing, I will pass things over to Tanya, who's going to walk through what's inside the toolkit and how organizations use it to support practical implementation.
Thanks, Amanda. Wow, I'm very sorry. So our slides format is not set up correctly here, but I just want to start with the results. We got 2 reds on the screen. The red on the left on the top is a median time to first dose of opioid. We worked with 4 different Ontario hospitals as to start our pilot for this toolkit. We wanted to decrease time to first opioid. That was our goal. The other red bar on the right is where you can see we had a pretty significant decrease across the board in terms of 44% improved median times to pain management. We also found there were improvements in time to physician initial assessment, increased order set utilizations, as well as compliance with correct CTAS assignment within the ED itself. So scaffolding the change, I only have about 3 minutes. I'm just going to kind of talk about what's in it. It's supposed to be a practical guide for project teams to walk through and do an implementation similar to what we just heard about in Hamilton. Every single day, my Instagram tells me, hey, Tanya, you're in perimenopause. You need to eat protein. Okay, how much protein? I don't know. Like, oh, hey, Tanya, you need to lift weights. How often do I have to lift weights? So this guide includes 5 complete ED order sets from all of the HIS vendors. So Epic, Meditech, Oracle Health, any hospital in Ontario that has these HIS systems can do that. It identifies key categories you need to have in your order set, including things like sublingual fentanyl for fast access to bridge those. We hear, okay, sublingual fentanyl will improve our times, but as project teams, well, what's the dose? What's the frequency? What's the monitoring look like afterwards? There's a lot of research that has to happen, and discovery from project teams, and so that kind of offers all of this. It also walks teams through a comprehensive root cause analysis. Do you have a policy in place? Do you have an algorithm documented to guide and also support the nurses to tell the physicians, hey, this is the protocol. We have an order set. You need to make sure the order set is actually ordered. Is there a bed available? What's the closest Pyxis medication where the sublingual fentanyl should be? We get a lot of good intentions to correct answers, but we're not always asking ourselves the right questions, and so that's what this guide offers. In addition to that, it really foundations a lot of this in investing in knowledge. We need to start from a place that there's a knowledge deficit existing here, and so not all organizations can provide comprehensive 8-hour training sessions. We know as clinicians, I'm a nurse by background, physicians, we don't get a comprehensive education when it comes to sickle cell disease in school. And so what we need to do is look at a breakdown so that at least there's a comprehensive glance at all these important areas, including like things like what are key priority areas. And that really does include empathy and building trust. And so we need data. Your health information system is set up so that it can be pulled coded data, but you need to have someone that can query it and pull it correctly so that it is accurate. So within this guide, it not only has the process indicators that you can use to measure your project, but it breaks it down from the types of medication. I don't want nobody looking at time to Tylenol. We need to look at times to meaningful medications, and then that can be communicated monthly to these project teams and evaluate. And then what's next from us? Well, guess what? We need to really look at the inpatient side. Last year, I don't know if he's here, Lance gave a really great talk about how patients with lived experience are receiving the quality standards. And it was pretty clearly identified, and I think it's ultimately true. There's still a lot of work to do on the inpatient side. We're seeing some changes in the EDs, but we're looking at things like updating admission order sets. sickle cell disease care plans that focus on functional pain management, things like recreational therapy and education and training, and something new that we're starting at North York General. Patients with sickle cell disease have surgery. They come out of surgery. We've got acute pain on top of chronic pain. It's different. Do we have a way for physicians to order a meaningful pain management set for this population? I'm at time, so feel free to chat with me after if we don't have time for questions.
Nice job. Thank you. I'm going to open up the floor for any questions. Okay, there we have one in the back.
My apologies if I don't remember the exact speaker on it, but someone had mentioned that the intent is to reduce the IV and just give oral medication, and that can be very helpful. But I have a question in regards to, I thought part of the reason for the IV was for fluid intake. So how does that get managed and dealt with?
So for us at North York General and other organizations that E2P has worked with, the sublingual fentanyl or those IV alternatives, that's a bridge. That's not really like management. It's just to accelerate the response to pain management. And so for things like IV fluids, like an IV would still be placed to draw blood. Fluids for vaso-occlusive pain episodes aren't typically given, but there could be other issues where that does need to happen. And so an IV would ultimately be placed, but just to avoid a patient waiting for multiple pokes or for that rapid pain management to happen, it's kind of like a bridge to that.
There's another one. Sorry.
Thank you. Good afternoon. My name is Ann Clark. I am not sure what question I have to ask, but I'll fumble it through. Post-operative, there was a piece there focusing on functional pain management. My little bit of knowledge, my understanding is people who live with sickle cell disease, they can manage pain up to about 10. It's even more than people who are pregnant, right? And I am looking at all of the different medicines, all of which are addictive. And I am asking myself, if my child, I had to make a decision about my child, would I want, in terms of pain management, would I want all of those drugs or any one of them? Or I would ask my child, where's your pain level right now and what can you manage before, and which one do you prefer, the Tylenol? Or maybe morphine, which is also addictive, but not as addictive. I'm going to stop there because I'm completely like, where's this going? And yes, we need to know more, especially the crises that we have across the country, particularly in BC. I could see a lot of people with sickle cell disease being in BC in areas where they just flick the switch for pain management and don't know where they are. I don't know if I made any sense, but that's okay. I'm still trying to get my head around what you just presented. Thank you.
That's right. I'll comment briefly, and I'm not fully qualified to comment fully. But what I will say is, when we look at the research, a patient with sickle cell disease does not over-index on addiction compared to the general population. That's period, the end. But when we look at research on clinicians themselves, the perception is that they do over-index. We did have a patient come in. they heard the term fentanyl and the social perception, they were concerned, like, ooh, maybe that is not for me, that could be highly addictive. And it happened to be, it was the mother was advocating and with them. This is an young adult patient, and said, hey, remember at Sick Kids? You used to always get intranasal fentanyl when you went through the door. And they're like, oh yeah. So while I'm not answering your question, I just wanted to leave those comments there, just like as a little bit of food for thought. And maybe we can find someone else in the room that's smarter than me. Thank you.
That was great. Thank you, Ms. Tanya and Ms. Amanda, for that informative presentation. Awesome. So just two more to go. And our next presenter is Marnie Cornett, Jasmine Montagnese, I'm sorry if I've mispronounced her name, and Sandra Newton, who will be presenting her abstract entitled, their abstract actually, entitled Partnering for Better Care, Development of Sickle Cell Disease Specific Chronic Pain Programming. Please join me in welcoming them to the platform.
Thank you very much. Great to be part of this panel and to learn as we also prepare to share on the topic of partnering for better care development of a sickle cell disease specific chronic pain program. We want to thank SCAGO for accepting our abstract and getting a chance to share this exciting collaboration, which, as you'll hear, involves the Sickle Cell Awareness Group of Ontario, but also the Interprofessional Pain and Addictions Recovery Clinic, or IPARC, at the Center for Addiction and Mental Health. I'm here representing SCAGO, and my wonderful colleagues Jasmine Montagnese and Marnie Cornett are part of the IPARC team, and you'll be hearing from them shortly. Disclosures would be our next slides. I do that. I'm sorry. As far as disclosures go, we do want to share that the Making Sense of Pain program that we'll be discussing is content that's been provided by Pain BC. And that's the extent of our disclosures. Okay, and then Jasmine.
Thank you so much, everyone. So we just wanted to kind of start by giving a bit of background. How did we get here? Why did we start developing this program? And essentially, as many folks in the room know, folks living with sickle cell disease in the Greater Toronto Area have very, very limited access to disease-specific chronic pain management programming. And so although there are many really wonderful hematology services in the GTA, access to this multidisciplinary chronic pain service remains very, very limited. And clients are often put in the position where they really need to rely upon more general clinics that may lack the unique expertise of chronic pain's care that is specific to sickle cell disease. And so as folks are aware, we have the Ontario Health's Sickle Cell Disease Quality Standards and the provincial model of care, which really has outlined some of the importance of making sure that we do have that chronic pain support as well as the acute. But we're here to talk more about the chronic pain support because the IPARC team here at CAMH did a collaboration with SCAGO as well as Pain BC to try and modify an existing chronic pain self-management program to address this specific gap. And so the existing chronic pain self-management program that we're going to talk about today is called Making Sense of Pain, and it was originally designed for folks who may be experiencing barriers to accessing these types of services.
I think I need to do that here, and I'll give it to you.
Right?
Sorry.
Okay.
I'm move myself.
This is teamwork in action, yes. So in terms of our objectives, we had 3 objectives for our partnership. So the first one was to modify the existing Making Sense of Pain group program content to be specific to the sickle cell disease context. Our second objective was to partner with those who have lived experience with sickle cell disease as well as chronic pain and our community collaborators in order to inform the program content. And lastly, we wanted to pilot the first cohort of the group using the modified curriculum.
Thank you. So in that vein, yeah, okay. I think things look a little different here and there, but that's okay. The important things are displayed. So as mentioned, we have this partnership, and that needed to be formalized between SCAGO and Pain BC and the iPark CAMH team. And that was achieved through various meetings and multiple memoranda of understanding, just to make sure that our terms were clear and agreeable to all. As facilitators, we also completed the facilitator training that Making Sense of Pain provides to those that are planning to implement the content. And the existing group content was reviewed, and we looked for sickle cell disease specific gaps. Again, this is a program intended for those dealing with pain in a sort of a generic model, and we knew the importance of tailoring it to audience. So we thought about gaps in content, and we made some preliminary modifications. And then, of course, it's important to have people with lived experience, people we considered stakeholders, review that and to let us know their response to it. So we had 4 folks that reviewed the material, go over it with us. These were people with experience in both sickle cell disease and chronic pain. And the content and group delivery process was modified accordingly. The table that you see will be familiar to some as what we call a SWOT analysis. This is where you look at the S for strengths, W for weaknesses, O for opportunities, T for strengths. And when we had those feedback sessions, we would organize the feedback we received according to those categories. Just an example of the modifications, because there may be interest in that. One of the things that we learned from our those with lived experience is that we should go beyond acute versus chronic and think more about something that would embrace the complexities of pain, the 5 types. Grief is a general topic within the curriculum, but we realize that it takes on a different meaning in the sickle cell context. So grief could be associated with the grief around a crisis, loss of others with sickle cell disease, and then unachieved, unrealized parts of one's life. So just appreciating the complexity of a term like grief and tailoring it to our group. And then the topic of nutrition. We really wanted to make sure in a barrier-reducing sort of program like this that we also followed suit, thinking about nutrition and thinking about budget-friendly meal resources. Those are the sorts of things we were able to share as part of this protocol. And then we put a call out to people that self-identified as having sickle cell and living with chronic pain, and completed the first pilot of the program, which was super exciting. And I will hand over to Marnie.
Thank you. Okay, so some of our results as well as expected results. So we're happy to say we were able to complete our first cohort, and we had a really wonderful retention rate. So we had a 73% retention rate, which anyone that works in groups knows that that's pretty good. So we had 11 people enroll. We had 3 folks that ended up withdrawing for a number of different reasons, and then 8 that were able to consistently attend with us. So participants reported having an increased understanding of chronic pain, the mechanisms, as well an amazing openness to discussing some of the self-management strategies that they already use, as well as learning from other folks and then some of the material that we had. Participants highlighted the real importance of fostering community with other people with sickle cell disease, as well as having increased access to a multidisciplinary team and additional care afterwards. We really appreciated hearing from Daniel this morning of the importance of having that mental health aspect as well, which was highlighted in the program. And so the additional participant feedback also highlighted that we used a virtual care setting, which was really helpful for folks to be able to join, as well as using strategies such as mindfulness and other strategies related to mental health were reported as being quite helpful throughout this process. And then, I mean, there's so much more that we could talk about, but I'm also trying to be conscious of time.
Okay. So we went through this. Okay, so in terms of our conclusion and relevance, so this collaborative partnership and our group programming highlights the necessity of chronic pain-specific care for those living with sickle cell disease, and specifically for it to be informed by community members, involving feedback from those with lived experience. And as we look ahead, we will continue to refine the content for the remaining 2 group cohorts. So we've completed our first cohort. Our second cohort actually begins next week. It'll go until October. And then we have a third cohort that will be in the winter time next year. So it's been an absolute pleasure to look at this content, modify the content, learn from those with lived experience, to make sure that it's relevant, effective, and meaningful. And I think I speak for my 2 colleagues here, just so energized by today. So just wanted to thank everybody for all their talks and just hearing from folks. We really hope to continue advancing the cause to improve care for those who experience chronic pain as well as sickle cell disease. So thank you.
Amazing. Thank you very much, our speakers. Are there any questions from our audience? Any questions? Okay, well, I got a question for you. You didn't get away that easily, did you?
Marnie's ready. Marnie's ready for your question.
Oh, awesome. I just wanted to ask, so I saw that some of the things that were some of your learnings, they seemed a bit like, I guess, subjective in terms of like the understanding, increased understanding of chronic pain mechanisms, you know, based on a person's scientific knowledge, maybe the layman terms, health literacy aspect. Just wondering, like, how did that impact your results? Like that whole level of understanding that can be different among your patients and the cohort.
Yeah, so it's a 10-week program, and so there's a lot that we cover, as we mentioned, like grief and nutrition, sleep, a number of different these aspects that we know contribute to chronic pain. All of our findings were subjective at this point. We are hoping to do we do take measurements as based of like a hospital-based program, but we're hoping to be able to use those for research purposes in the future by going through, you know, the proper ethics boards and pieces like that. But at this point, it was all qualitative, which folks were really generous with their time and kind of outtake meetings as well as intakes and sharing what their experiences were.
That's great. And just to add on to that, I was just wondering, like, are you guys planning on incorporating any AI you know, in your technology for improving like qualitative, quantitative analysis? Sorry, I see your eyes open wide. So, I mean, it might be a great opportunity. I think this is the PhD side of me coming out. Sorry.
No, I think it would be a wonderful opportunity. I will always say, hospitals sometimes move very slowly when it comes to some of these technology adaptations. I know there has been talk of trying to include AI in some of these areas, which we have seen particularly with physician-led initiatives. We would love to see those types of initiatives potentially be led, but kind of led by what patients kind of feel are going to be the most relevant at the time. So we don't have any plans for that at this point in time.
Sounds great. Thank you. Let's give a round of applause for our presenters for that excellent session. Last but not least, hopefully I didn't drop that paper. Oh, I did not, Karen. Okay. We have our final 2 presenters who will come to the platform. So we have Ms. Karen Fleming from Lake Ridge, and I will do my best to say this name. It's a beautiful name, Birgit.
Umaigba Omari.
Beautiful. I didn't want to murder that. It's such a beautiful name.
Thank you.
So they'll be presenting to us. She's from Durham Community Health Center. So we're excited to have these 2 as our last speakers, who will present to us on co-creating culturally affirming sickle cell disease services through community hospital partnerships in Durham region. So please join me in welcoming our speakers to the stage.
Good afternoon, everyone. Thank you so much. Thank you, SCAGO, for having us here today. We're excited to be here together to share about our collaboration. We have no disclosures.
All right. Yeah, that's you, right? Yeah, go. Sure. So thank you so much, everyone, for the introduction. I really want to say thank you to our clinical team at Durham Community Health Center, Rana Hariri, Salome Odeni, Olatomi Thomas Obeo. They have been instrumental to this work. I just wanted to recognize them. Thank you, Karen. We we've heard a lot today, and we've seen people living with, sickle cell disease. We work with them closely, and we do know that, people with sickle cell disease require comprehensive care across, the care continuum and throughout your lifespan. And in order to be able to provide care that is culturally affirming and is also centered on what they need and community-driven, we've collaborated with Lake Ridge Health, and I've intentionally launched the Durham Sickle Cell Wellness Services, supported by the Black Health and Wellness team at Durham Community Health Center. The objectives of this intentional collaboration are really to increase awareness of our services in the community, to co-create and co-design services. And again, the most important element is to build trust between Black communities and healthcare providers. And we know historically trust is an issue. So we're very intentional on that. So our goal really is to identify the needs through engagement. So we actually do run events all across the community in Durham through a mobile clinic. We actually have a clinic on wheels to do that. So again, co-designing services that reflect the principles of cultural humility, anti-racism, and the Ontario Health Quality Standards for SCD. In terms of our methods, in order to be able to actually co-create, because it's not always easy to bring what the patients need or the clients need and then to tailor that to the services that we have. So we've used a community-engaged approach by attempting to engage clients with SCD at Durham Community Health Center through the electronic medical record system to invite them to community event for connection and to hear their voice regarding what quality care looks like for them. Other trust-building strategies that we've incorporated include SCD education sessions to healthcare providers at DCHC and at Lake Ridge Health, and thanks to my colleague, Karen Fleming, she's been instrumental in providing this educational sessions. We've also provided education to community members through our clinicians, health promoters. Again, participation in community outreach events is huge for us, so whenever we are out in the community, we want to make sure we have our mobile van, our clinic on wheels, where we not only showcase the services that we have, but we do blood pressure tests, we do screenings, and it's just a great way to say, hey, the services don't end in the hospital. Again, the mobile SCD screening initiatives is delivered in collaboration with Lake Ridge Health. And these activities are actually just designed to increase awareness, because oftentimes people don't know the services that are out there in the community. And as healthcare providers, we do take for granted how much people may not be aware. People may not know the basics of what we know and the information that, we're, that are at our disposal. Oh, okay. That's not what's showing on mine. But you know what? I have a backup. So what we did is we actually engaged community through a brief survey as one of our trust building steps to just start gaining appreciation of who the Durham community members are, those living with sickle cell disease, their caregivers, and the needs from the DSCWS. So there were 11 responses, and some of the results are, I'm just going to read them because you can't see them. Some of the questions were, do you have sickle cell disease? And we had like 45% of the respondents say, yes, I have SCD. 18% said no. They answered no to the questions that we had to that we asked. And then 36% of the respondents actually said, no, but I do have a family member or a caregiver of an adult with SCD, so I'm sure a lot of us can relate to that. A lot of families and a lot of people will have family members with SCD. And one of the other questions again was, what is the age group of the individuals with SCD? So we had a range from age 0 to age over 65 years old. And we had, age 0 to 12 years old, we had one, 13 to 18 years old, another one, 19 to 30 years old. So what we saw is that 36% was actually within that age group of 30 to 65 years old. So that's really the age group that I want to highlight. And then another question was, do you have pain episodes where you have to seek care in the emergency department, we had 55% of the respondents say yes. So that's quite high. And then, do you seek care at one of Lake Ridge Health emergency departments? And we had 38% of people say no. I avoid Lake Ridge Health Emergency Department. So that was really important for us, like, to explore the reasons why are they avoiding, and they're in pain, but why are they not seeking care at Lake Ridge Health? And then about 25% did say yes every time. I'm just gonna hand over to Karen for the discussion.
Thank you.
Yep.
So we have talked a lot about the barriers, so you guys have heard, because just to start off with our discussion, what are the actual barriers that patients experience? So stigmatized experiences, avoiding the emergency department, avoiding interaction with the healthcare system for many of the stories we have heard today, being falsely accused by being perceived, that can't be our time already, sorry. Being falsely accused of being a drug seeker, not being able to report their pain appropriately, and then distant acute care or their dedicated sickle cell centers, especially with us being in the East End, they're quite a distance away from where our community lives. So then for community-centered, I think if you click it again, the next thing will come up. So for community-centered, if I click it, she's got my back, see? She got my back. So community-centered service development. So this is just, and yes, I use Napkin AI, right? I want to disclose, I did use some AI. And I used it to create these things, because why not? So listening, right? So active listening, we heard that today from a number of individuals who have sickle cell. I feel like it's the thing I heard the most today, was listen. Right? And actively, I almost feel like I would say empathetic listening, right? Listening to hear, to just listen. I have no plan. I just want to hear what you have to say. To really partner, and not just partner with like DCHC and Lake Ridge Health, but there's a number of other services within Durham Community Health Center and external to the Community Health Center that we can leverage as partners. We want to prioritize the perspective of community members, hence why we're really trying to engage our community and hear directly from them. And then the survey findings showed us quite explicitly that they don't go to Lake Ridge Health. So we really do want to unpack that. We know that. We know 50% of our clients leave our catchment area to go to Scarborough or to go downtown. Why are they leaving? And then this survey further says that for the small group of people we got to ask, almost 40% said they don't come to Lake Ridge Health. So what are our opportunities? So the cycle of SCD care enhancement, I'm going to speak a little bit faster. You will see that building trust at the very top. And it's something we're really keen on. It's essential. We can't move forward until we build trust with the community, and with the community already has so much mistrust of our Durham services, or really healthcare services as an individual with sickle cell. Expand our services, so once we do build that trust and we understand what's needed, being able to expand our services so they're closer to home, strengthening our partnerships that help us to expand those services, and all of this will help to contribute to an improved quality of life and ensure high quality care. So in conclusion, we have successfully enrolled some new clients into the Durham Sickle Cell Wellness Services, providing access to an interprofessional team who's focused on supporting both their primary care and sickle cell specific health needs, and I would tack on to that are culturally affirming. Through Durham Community Health Center, clients can access a broader range of wraparound services, including Kliniki, the Black Health and Wellness team. Oh, great, I have it there. Culturally affirming mental health supports, which I just want to tack on. Any individual who gets enrolled into Durham Sickle Cell Wellness Services, there's a baseline mental health assessment done with the therapist. Youth services, I thought she was getting up to come over here. Youth services, senior services, uninsured client supports. So there's a number of connections, because I do think community health centers are so amazing. There's so much you can get from this. So if you don't know about community health centers, get to know them better. They're fantastic for especially patients with complex care conditions. Intentional collaboration for us, by us, culturally affirming care, trust building. I'm going to leave it there. Thank you.
Thank you to our speakers for an informative presentation. All right, I think we have time for one question, just one. So who's the lucky candidate who, oh, perfect, okay. They thought they got away.
Yes, money from mommy.
Last question of the day.
Thank you very much. I really enjoyed your presentation, but I think there's one thing that I haven't heard anybody talk about is what to look for when the narcotics are leaving your child's system and how it alters their behavior. Because I noticed that sometimes when my child receives the fentanyl and everything in the emerge before we go upstairs, as it's coming out of her system, she has certain symptoms that affects her emotionally. And nobody prepares you at 2 o'clock in the morning when the drug is leaving the system and your child is halfway hallucinating and saying certain things they're not supposed to say, and there's nobody to reach out to at that very moment. And so if there's any sort of education as to if your child received fentanyl or if your child received Contin and it's coming out of their system, this is what you look for and this is how you support them. Thank you.
I think you present a really good question. And I wonder a little bit about some parental experiences. I would think it's individualized in one way, that each child is going to, or each person in general, the way that they respond to an opioid is going to be different. I think track what's happening to your child and maybe then go back to your team and say, hey, you know, like 3 hours after she got the opioid, this is kind of what was going on. Is this normal? Is this what I should be expecting? Start asking questions. Don't wait for, you know, someone, you know, just go to your team and specifically say, this is what happened and I am not sure if this is normal, so that you're ready and you're expecting it. And if it's not normal, then they'll be like, okay, maybe that dose wasn't right. Maybe the drug wasn't right. So I do think take it back to your team and making notes. I feel that's something individuals, you know, warriors do and families do, a lot of note-taking around your experiences and when something might not be quite right. Okay.
Thank you very much. That was a speedy answer, very efficient. Awesome. Let's give our presenters a round of applause. So thank you everyone for